chapter 26, which is all about measuring vital signs, which is something you guys have already practiced, but we haven't gone over the actual content of this chapter. So, okay, so basically, when we are measuring vital signs for our patients, we're worried about 4 different vital signs, okay? We want temperature, pulse, respirations, and blood pressure. Those are the ones we kind of hone in on. So basically what we're trying to do is trying to detect any changes in the normal body function, okay? And the vital signs are what is going to give us that information and tell us something is wrong. So it also helps us sometimes tell about the response to a treatment. You know, if you're taking blood pressure medicine, the best way to see if that's working is to what? Check your blood pressure, right? Okay. So a lot of times we can also figure out some very life-threatening events that are going on based on your vital signs. You know, I've measured pulses that were in the 40s and 30s at times, which were signaling to me that there was this was a definite life-threatening event. Or I've measured blood pressures that were just through the roof. Okay, it's very scary. Now, a part of this assessment step, vital signs are part of that nursing process that we're going to do, which you guys are a part of. This is the information that you guys are very capable of getting as part of the nursing process. Now, the times that we're usually going to measure vital signs, of course, are going to be during a physical exam. Every time you go to the doctor's office, that's one of the first things they do, right? When a person gets admitted to the facility, we have this huge admission packet that we have to do on a lot of information we have to fill out, and of course vital signs is one of those things that we're going to collect at that time. Basically, we're going to order vital signs and do vital signs as often as that person's condition requires. You know, if they are very sick at the time, then, you know, we're going to increase how often we do vital signs. Now, before and after surgery, especially right after surgery, when you first go into the PACU after you've had surgery, they check it every 15 minutes for about an hour, then maybe every 30 minutes for an hour, then every hour. I mean, they kind of gradually decrease it if everything is normal, but when you first get out of surgery, I mean, they are constantly coming in and getting your blood pressure and different vital signs. Now, sometimes after we've done certain care measures, like, you know, walking someone or, you know, ambulating someone, we're going to check their vital signs to see, okay, maybe your blood pressure is fine most of the time, but if I get up and walk you, where I should see a small increase, maybe your blood pressure is just going through the roof, and that's not normal, okay? But it's only through physical activity that I can detect that, okay? Again, medications. We do have a lot of medications that can affect your respiratory and circulatory system. Any complaints of pain, dizziness, lightheadedness, shortness of breath, rapid heart rate, or just in general, hey, I don't feel good. I don't really know what's wrong, but I just don't feel good. That's the time we're going to check vital signs. And again, anytime it's stated in your care plan, you just do it. Now, getting vital signs and making sure you do a very accurate job at that is extremely important, especially when we deal with a population who you're more likely to have abnormals, okay? So that's why I always, you know, even as a nurse, sometimes might have trouble hearing somebody's blood pressure. I'm not going to be too proud to ask my other coworker and say, man, I just can't get her blood pressure. Can you please help me? Okay. A friend of mine's mom over the weekend was having some heart problems. Went to the doctor. They gave her some medicine, and then her daughter came in and said, "Well, I want to take you to Evansville, Indiana." And she had another spell on the way to Evansville, Indiana. And when they went to find her temperature, they could not find it. And eventually, they finally had to actually take it rectally and finally got a temp on her because she was having such problems. But, you know, there are times that you're going to have problems and issues trying to get someone's vital signs. That's when you got to call in your, you know, hey, come help me with this, okay? And don't be too proud to do that. So make sure, I mean, unless it's ordered different on their care plan, you want to take the vital signs when they are either lying down or sitting, okay? And the person is at rest. When we take vital signs, why? Exercise affects your blood pressure and pulse, correct, and respirations, right? So we want them to be at rest for at least, 10, 15 minutes, before we take their vital signs. My mom just got off some blood pressure medicine, has been trying to check her blood pressure, and she goes, well, it's still running a little bit high, because she's been checking it at Walmart. I'm like, what were you doing right before you were getting your blood pressure? Shopping. I'm like, that involves pushing a cart and walking. Don't you think that's gonna, it's not gonna be as accurate, it's gonna be higher, because you're actually not resting before you get that blood pressure. So she was kind of freaking out for nothing, okay? Now, again, if you have any type of vital sign that's different than what you normally see out of your patients, you're gonna wanna report that to your nurse if you see some kind of major changes. If above the range, even sometimes if it's below the range. Did you know you're actually as much or more at risk for a stroke from your blood pressure going too low as it would be from going too high? You can actually have a stroke from your blood pressure dropping too low. So that's something that most people don't think about or know. So that's why, we report anything that's above normal or below normal, okay? And also, again, if you cannot measure vital signs, if you're having a hard time measuring the vital signs, let your nurse know. Now, body temperature basically is the amount of heat that's produced by your body. Obviously, we're going to use a thermometer for that. I know at meals you guys saw the thermometer that's actually attached to the vital sign machine. But there's a whole lot of different things that you can use to do temperatures with, a lot of different thermometers. We have the old school now that's non-mercury that you guys probably use in intro class to learn how to take an oral temperature. Then a lot of times these days we use digital thermometers. And now, like the last thermometer I bought was an infrared thermometer, okay? The infrared thermometers, you hold about 1 inch from the forehead. You push the button, it sends an infrared ray, hits the skin and comes back, and it tells you what your temperature is without touching your patient. And it's pretty much instantaneous, okay? Oral thermometers, the one that go in your ears, some people still use those, but a lot of them use the little scans. They'll scan your forehead, okay? And those also use an infrared ray to detect a temperature, but I like the one that doesn't actually touch the patient, because your infection control risk goes down greatly. Now, when we measure, I know that you can measure either in Fahrenheit or centigrade. I've never had anyone measure anything in centigrade in real life scenarios. We always use Fahrenheit. And again, mouth, rectum, axilla, which is where? Armpit, yeah, under the arm. Tympanic membrane, which is where? Ear, good. And then you have the temporal artery, okay, that we talked about, the little scanners. Now, again, if they have an elevated temperature, that's going to be called a fever, and you're always going to report any above or below normal temperature ranges. Now, just remember though, a lot of times older folks have lower temperatures than we do. So if they have a 97, that might be their normal. So everyone's temperature can vary. So again, that's why we say, well, we want to report anything that's different than normal. Okay, because our normal might be 97.3 something. All right, so again, we talked about the glass thermometers, electronic thermometers, digital, disposable oral thermometers. Sometimes when I used to give blood, they would have this little plastic thing they'd stick under, and it would heat up and change colors on the end of it to where they could see what my temperature was, and then they would just throw that away. I have seen also stickers you can put on your kid's forehead. Like a lot of times if you want to see what your kid's temperature is, it kind of reminds me of those mood rings. You know, you stick it on, and depending on what your body temperature is, it's going to change colors. And again, that's kind of, I guess, the process behind those little stickers you can stick on their forehead, and that way at night, instead of waking them up, you can see what their temperature is. Okay. Temperature sensitive tape, that's again kind of something we were just talking about. Okay. Now, pulse. Pulse is basically the blood pumping through your vein. That's what you're feeling every time your heart beats. You should feel a beat of the pulse. Okay. And again, we're going to feel that in the artery as that wave of blood passes through that artery. We have several different pulse sizes that we can use. Where's the temporal at? Right, temporal, carotid. Right, and when do we use the carotid the most? Do you remember what type of situation when you are checking for a pulse you use carotid? CPR, very good. Now, what about brachial? Brachial, radial. Good. Okay. When do we use a brachial pulse?
Blood pressure.
Blood pressures. When do we use radial pulse?
Taking their
Pretty much all the time, right? Radial is the most common spot that we're going to take a pulse at. So, you also have popliteal, which is behind the knee, posterior tibial, which we never use, dorsalis, pedis, or the pedal pulse is sometimes what we call it. I actually use those quite a bit in geriatrics. Okay, we have a lot of patients who wear TED hose. We have a lot of patients who have a lot of circulatory problems, and they end up, you know, if you have bad circulation, you're going to lose circulation first in your extremities. So that would be your feet. And what we do, that's the top of the foot. A lot of times we check for circulation there and check pulses to see if you can feel the pulse in there, because we want to see how the circulation is going in their feet and legs. Okay, so we actually use that quite a bit. Now, again, radial is your most common one you're ever going to use, and then carotid and CPR emergencies. And then apical pulse. Apical pulse is something we actually listen to through a stethoscope over the apex of the heart. Okay, and again, you're just going to listen and count that just as you would any other pulse. Now, when you use a stethoscope, again, you'll always want to make sure and use infection control practices by wiping off the diaphragm or the bell, whichever you want to call it, with an alcohol pad, as well as the earpieces. Because most of the time, nurses a lot of times will carry their own stethoscopes, but the CNAs a lot of times don't, because usually they just have one there that everybody uses, kind of a community property. And that's why you want to make sure that you're wiping it off good. You want to wipe it off in between patients as well. You know, mostly I'm talking about like the bell of the stethoscope, as well as the tubing. We like to make sure we're not sharing the love between patients. Okay. You have to be real careful about stuff like that. Now, of course, you're going to put the earpiece in your ear, put the diaphragm over the artery, and try to prevent any outside noise whatsoever when you're trying to use that. Now, when we measure pulse, we use it how many heartbeats are in 1 minute. You know, the best practice would be to count it for a minute. Now, according to who your patient is going to vary on your pulse rate, okay? And because like a child, have any of you ever seen like had a family member who had a baby? Maybe you went to go see the ultrasound, or maybe you just went to the visit with them and heard anything about a heart rate on babies? Any clues as to what that might be? I don't know if you guys would or not. So it would not be uncommon for a baby to have a heart rate of 120, maybe even 140. Okay, and then of course as you get older, it gets a little less and less and less until grown-ups. Ours is more like 60 to 90 would be normal for us. So again, you have to take in mind what patient you have before you figure out what the normal is going to be for your patient. Now, 60 to 100 is what they're going to give us here for a normal adult. Now, if it's over 100, we're going to say that they have tachycardia. tachycardia, tachy meaning fast and cardia meaning heart, of course. And then you have bradycardia if it's under 60. And again, that might be a normal though for your patients, especially if they're on certain medications. There's a medication we give called digoxin, which helps regulate your heartbeat. And before you can actually administer digoxin to your patient, you have to check their pulse first, because it lowers your heart rate. And if they have a starting pulse that's below, 55, 50, or below 60 to start with, sometimes you have to hold that digoxin and not give it to your patients. So that'll be a practice you'll do a lot whenever you're administering medications. Now, rhythm and force. Rhythm should be regular. We would expect that heart to beat at the same time every time. We would not expect it to skip a beat or double beat real quick. Okay, that would be irregular. And when we are charting our pulse, we do chart it as regular or irregular according to that rhythm. Now, the force is the strength of that pulse coming through. We would expect a good, strong, full, maybe bounding pulse. It shouldn't be that hard to find, okay? But if you are having trouble finding it, and then we would call that maybe a weak pulse, a thready pulse. Feeble, I don't see as much. Most of the time I see as weak or thready is the two main descriptive words in charting that we would use. And again, you have to be very accurate at counting the pulse. You guys will have to do that, for your MNA testing, and make sure that it's good and accurate. Now, apical radial pulse. Now, your apical pulse is on the left side of the chest, slightly below the nipple. You take it with a stethoscope, you count it for 1 minute, and again, the way they describe one beat is loved up, loved up, loved up, okay, because you can hear it when you actually use a stethoscope, that kind of you have the heart beating in, contracting, and then releasing again. So you have loved up, loved up, loved up is what you should be hearing. That's the way the words they use to describe that. So again, when you take an apical pulse, it should be the same as a radial pulse for a normal patient. But there could be certain health problems and things that would make that not true, and that's why we actually check and see if there is a difference, okay? So, and what you want to do if you're taking an apical or radial pulse is you have to have a partner with you to do that, because one of you is going to listen, you're going to start counting at the same time. One of you doing apical pulse and one of you doing the radial, okay? And you guys are going to kind of count down, okay, now start, and you're going to count for a full minute. At the end of that full minute, you're both going to document what you got as the pulse, and we're going to look for any kind of a pulse deficit, okay? And a pulse deficit would be the difference, when you subtracted the apical and radial pulses, what is the difference, okay? Now, again, that's called taking an apical radial pulse, okay? Respirations, basically, when breathing in, inhalation, and you breathe out, exhalation, that counts as one breath when you're counting respirations, okay? Again, you're breathing in oxygen, breathing out carbon dioxide, and you should see the chest rise and fall for one breath, okay? For an adult, you should see somewhere between 12 and 20, and that would be our norms. Again, you shouldn't be able to hear someone breathing necessarily. It should be just a normal, regular, quiet breath. Both sides of the chest should raise and fall equally whenever you see a breath or there's some major problems. And again, you should count respirations at rest, because we've already said that what happens that would throw it off?
Exercise.
Any kind of exercise. So we want to count your respirations while you are at rest. Again, when we are in practice and I have just counted your pulse, I continue to hold your wrist and pretend like I'm counting your pulse, but in reality I'm looking for the rise and fall of your chest, and I'm counting your respirations. Why would I do that?
Because people.
They could be watching you.
Right. If they know you're counting their respirations, they will start breathing really funky because they know because then all of a sudden they become aware of breathing. Most of the time we breathe all the time and think nothing about it, but if you know someone is watching you breathe, you become very aware of your breaths, and you will start breathing irregularly or just differently. So we pretend like we're still taking the pulse, but we actually, after we actually count the pulse, then we start counting respirations all this at the same time, okay? And again, you watch the chest rise and fall. That would be 1. Rise and fall, 2. Rise and fall, 3. Okay? Now, blood pressure is basically, it's the force, the amount of pressure inside that artery because of blood. Okay? Now, our arteries are kind of stretchy, so depending on the blood volume in there, you may have more or less blood pressure. Okay? Just like you have more pressure inside of a water hose, the more water that's in there, right? And then the less water you have, then you have less pressure. So the things in your body that actually control that blood pressure, again, sometimes are the force of the heart contractions. If you have a weak heart, you're going to have a lower blood pressure because it can't physically force as much blood out at one time, right? Okay. Again, the amount of blood pumped with each heartbeat, which sometimes can change depending on if there are problems in your heart that do not allow all of the blood to get from one chamber to another. That can cause a difference. And then again, how easily the blood can flow through your blood vessels. What are some things you can think of that might make a difference in how easily the blood can flow through your blood vessels?
Blood thinners.
Blood thinners, that would be something because it makes it easier to pass through. Alcohol, that would thin your blood and make it easier to pass through. Drinking a lot of liquids, that would change things. What about the veins itself? Any conditions, any diagnosis that could happen inside of your veins and arteries that would make a difference?
Buildup of plaque.
A buildup of plaque. Okay, that's because if the passageway is somewhat blocked, it's harder to get through, isn't it? Good. Another thing I think about, which a lot of elderly people have, is called arteriosclerosis. Okay, and which is a word which basically means these flexible arteries that we have get somewhat hardened and they can't flex like they used to. Okay, so the hardening of the arteries will definitely make a difference. Good job, guys. Now, let's talk about systole and diastole. Systole is when the heart muscle actually contracts, okay, which is why you have a systolic number on top. Diastole is the heart at rest, okay, which is why you have the diastolic also. You have systolic and diastolic, okay?